A very good morning to all of you and a warm welcome to this instruction course on multifocals. We'll be speaking about the various multifocal options which are there. Though the topic is technology for multifocals or technology for presbyopia correction, we'll be talking only about the intraocular lenses options, and we won't be talking about the corneal correcting procedures. So that will be the focus. And as I have hinted in the topic, we plan to give honest opinions. That is, opinions which are based on our personal experience and the patients and the results which have come in the patients, and not colored by any marketing pressures or personal preferences. So ultimately, actually, it is our duty to make the patient happy, because if the patient is unhappy, it is we who have to face the patient and not the marketing people. So that is something we all have to remember, and is the point which I would like to drive home. So with these few words, we'll move to the first talk, which is by myself, technology for multifocals, what is essential, what is not.
Dr. Anup Chirayat does not need any introduction to the audience, but for formality's sake, he's a prolific anterior segment surgeon, very well experienced in all sorts of IOL technologies, and he's the director of iVision Eye Hospital, Thrissur. Over to you, Dr. Anup.
Thank you, Dr. Soni. So it has been written somewhere that it is in the literature that it is nearly impossible to create a lens which gives a perfect image at varying distances with no aberration and with no loss of light. What it essentially means that it is not possible to give God-given sight, like to a person, to a human being who is emmetrope in the pre-presbyopic age. But yes, multifocal IOLs are a technology and evolution, because the lenses that we used 10 years back and the lenses which are available now, there is a dramatic difference between the two, between the results. As all those who would have used the earlier generation of multifocals and the present one will definitely vouch for it. Now the patients are much more happier, but it is still technology and evolution. So as would have been said thousands of times, that what is most important is the proper patient selection, and which should be based, patient selection which should be based on the lifestyle of the patient, that is the hobbies and what are the things that the patient likes to do, the personality of the patient and the needs of the patient. So ultimately, one should always choose a patient who is motivated. That is, somebody who doesn't want to use glasses is always the best patient, because they are unlikely to complain post-operatively. And those who are pre-operative hyperopes, that is, they are the patients who have neither distant nor near vision clear. So they are the people who will be definitely happy. And definitely avoid the hypercritical or demanding patients, occupational night drivers, and those who have undergone a previous refractive surgery. There is an irony in that, because these are the patients who are motivated, because that is why they underwent refractive surgery in the first place. But unfortunately, in these patients, we cannot guarantee emmetropia after surgery. And low to moderate myopes also, they are used to such clear near vision without glasses that none of the present generation IOLs can guarantee that sort of near vision. So what is the technology we are talking about? There is nothing great in the technology. One is the patient questionnaire. That is, these questionnaires the company people themselves give us, and which we have to modify it based on our the patients in our own locality and the culture of our own patients. An ultrasound biometer with immersion is more than enough, because we have been we used to do immersion biometry as well as we also have optical. So just to cross verify the two, so that we can pick up if one machine is not working well, at least the other one, if there is a difference, then we again recheck. So while doing that study in a hospital, we found hardly any difference in the axial length measurement between ultrasound with biometer and optical biometer. A good slit lamp, it is important, because I think that is something which is really important. If you want to invest somewhere, please invest in a good slit lamp, because any small amount of donuses, like small subluxations, iridodonuses, phacodonuses, or small subtle opacities near the pupillary area, those things can be picked up only with a good slit lamp. And always we have to use newer formula. We have those available online. because they are the ones which will give you more, will guarantee you emmetropia post-op. And a good microscope and phaco machine, which anyway as a phaco surgeon you will definitely be having. Some things are an luxury, but they may not be essential, like an optical biometer, which is gradually, probably over a period of time, it will become essential, because since everybody will be having it. But still it is not essential. Toric assisting devices, like for example, if you are planning toric multifocals, then like the Varion or Callisto, they are also not essential. And I wish the eye trace tonometer for measuring angle kappa and angle alpha, which is, they say there is importance, I'll be speaking about that. And the ORA, which is the new kid on the block, which is something like a biome which we attach to the microscope. So that is, which gives a real-time biometry. That is, after you have removed the cataract, in the aphakic state, you will get the biometry. So what the advantage they say is that already the sections have been made and the effect of the sections on the cornea has already been there. So after that, you are measuring the biometry, is more likely to be more accurate, but also definitely extremely costly. So coming to angle alpha and angle kappa. Angle alpha, as you know, is the difference between the center of the limbus and the visual axis. That is, from limbus to limbus, the center of that. So what we effectively mean is the center of the capsular bag or the center of the implanted IOL. So between that and the visual axis, that is light passing through the object of interest to the fovea. Angle kappa, on the other hand, is the difference between the center of the pupil and the visual axis. So if you see the first image on the upper part, so there all these three dots are almost in the almost overlapping or near to each other. So this is the ideal situation. And in the lower image, you find those three dots are separated. And in that, if you see, the yellow one is the visual axis and the green one is the optical center. So there is a big difference in the gap between the two. So what it means is that those rings of the multifocal lens will not be uniformly exposed in the pupil. So it will be like the central ring would be slightly ectopic. So that is not what is desirable. So at the same time, there is no absolute consensus on the range of angle kappa and angle alpha. Generally, it is said that if it is more than 0.5 millimeter, that is horizontally measured on the cornea, if it is more than 0.5 millimeter, the angle kappa and the angle alpha, then the patient may not get optimal vision. But it can be measured only with the eye trace aberrometer. You can even measure, they say, with a autorefractometer, but I have not tried that. Tips for success, again repeating the same thing, the proper patient selection, accurate biometry, always aim for emmetropia or slight hyperopia, never aim for myopia. Use newer formulas, good surgical technique, because if your phaco is good, you should attempt for a multifocal. All steps are crucial. Proper lens selection based on the patient's personality type. And ultimately, the patient should be clear about their priorities. A confused patient is not a right patient. The patient should know what I like and what I don't like. Sometimes all patients are not very clear about what they want. And the surgeon should be clear about the options, about all the lenses which are available, the pluses and minuses of each lens. And the marketing people, they will never tell you about the minus things. They will say that institute they are using, this institute they are using, and they are having excellent results. But you have to go through the details about the pluses and minuses of those lenses. You have to talk to your friends who are using it, so they will give you a proper guidance. So operating on these lenses, like I said, all surgical steps are important. The sections should be good, and most importantly, the rexes, it should be round, it should be well centered, and it should be circular, around 5 to 5.5 millimeter. And after implanting the lens, I always implant under BSS. So the lesser the visco, better, because once you removing all the visco is at night. And at the end of the procedure, this is important. You have to tinker around with the lens with irrigation, so that the lens is well centered and all those Purkinje images should be there in the central zone. The first and fourth, I will just show you again. And this is a toric multifocal. So again, I always still mark all my torics on the slit lamp with a beam of the slit lamp. and I have hardly never got any patient who was unhappy. I was complained that my axis is decentered. I am not saying that all my lenses are on the dot, toric, but a slit lamp gives excellent result. And here again, after inserting the lens, you have to, the last you have to spend some time, you have to, like you're tinkering around with the lens, so to see that, you just, you shake it around and see that it is well centered. And always, I always try to mark the axis, even if the axis is less than 1 diopter. Always mark the axis so that you can keep your steep, your incision can be made on the steep meridian. So even the 0.5 diopter of astigmatism can be reduced by at least 0.3 millimeters. So after that, this is the coaxial light. If your microscope has oblique as well as coaxial, you switch off the coaxial and only with the, switch off the oblique, and only with the coaxial you ask the patient to look at the light, so that the, you know, that is the visual axis. And your fourth and your first and fourth Purkinje image should fall within that central area. This is marking the steep axis. This is not a toric. And then making the section on the steep axis. You can see those Purkinje images. All of them are in the central zone. This is a EDOF lens, the non-diffractive type, the VVT. And at the same time, I also feel proud to say that a lot of our Indian companies also are making excellent all the trifocals as well as EDOF lenses. So this is an Indian make of a trifocal lens, and they also have excellent results. It's not necessary that you have to use only the extremely costly the multinational lenses. Even the Indian make ones give good results. So those are the Purkinje images. So aligning the first and fourth with the coaxial light of the microscope, the reflection should be in the innermost ring. Unhappy patients, those with lens decentrations or tilt, which may occur if your axis is not centered. Those with inadequate pupil size, that is, some people, they after surgery the pupil shrinks a lot, comes to almost a very 1 to 2 millimeters. So in that you don't get the benefit of the multifocal. Residual refractive error, posterior capsular opacification, which can be easily managed. Patients with photopsias and those with dry eyes. And though you may have advised multifocal, you should always be willing for a change of plan, because if there is a large PCR, you have to place the IOL in the sulcus. If there is a zonulodialysis, a CCC tear or a pupil trauma, then you may have to shift to another lens, because in these situations the lens, your multifocal may not be centered well. So optimizing results, binocular summation, what it means is that you have to implant the same lens in both eyes and with not too much of a gap. And neuroadaptation, which is a lifesaver for many of us, which basically means the patient adjusts by himself over a period of time. So patient after 3 months may not really complain as much as the patient complains the next day. So never try to do anything interventions immediately after surgery. You tell the patient everything will be okay, and come after again after 3 months. 90% of patients they won't come back. Mix and match again is also possible. The newer modalities, that is enhanced monofocal with micro mono vision. The low add EDOF in one eye, dominant eye, and the higher add EDOF in the non-dominant. EDOF in the dominant eye, and trifocal or multifocal in the non-dominant. In special situations, young patients, EDOFs are better because you don't know in future what their maculas would be like. And diseased eyes like corneal opacities, glaucoma, macular pathologies, always best is monofocals, or if at all, you can go for a non-diffractive EDOF. Newer lenses, like I said, technology and evolution, newer lenses are keeping on coming in the market. The one with the black ring is the IC8 Aphthera by Bausch & Lomb. So it's a monofocal lens with enhanced depth. A clear view lens by Lenstech, so that instead of diffractive rings, it has got segments. So all the advantages are diffractive, but the glare and halos are less, is what they claim. And the third one is a very the light adjustable lens. It's like futuristic, but it is available where after implanting the lens, post-operatively you can modify the power of the lens by exposing the eyes to UV light. So you can change the power of the lens. So that is available, FDA approved and available in the US. I don't think it has come to the Indian market. But that is something gratifying, but still a long way to go. Yeah. Thank you.
Thank you, Dr. Anup, for that exhaustive overview on multifocals and EDOF technologies. Can I ask you one question? Yeah. There is a definite overlap between the enhanced depth of focus and the so-called EDOFs. So, when you talk about using it in young patients or diseased eyes, would you go for an enhanced depth of vision or the ex-EDOF or the modified EDOFs?
I would always prefer the enhanced monofocals because whatever said and done, already their contrast sensitivity and their is already would have been reduced because of maculopathology, maybe macular edema, whatever the reason, or the corneal opacity also. So monofocals or enhanced monofocals. They say that they do give non-diffractive EDOFs also in those patients who demand it, but I personally would prefer enhanced monofocal. Yeah, thank you.
Thank you.
The next talk is on enhanced monofocals with micro monovision, for which we have the very experienced and high volume phacosurgeon, the flamboyant Dr. Srini Adaklan. Welcome.
Thank you, Dr. Anup. See, it's really nice to see full halls. When I go for mini conferences, last week I was at Karnataka conference. The hall had 5 people. We have quite a bit. That's very gratifying. So, once again, thank you. Thank you for this opportunity, Dr. Anup. So, if we Dr. Anup has given an overview of all the IOLs. So, if you are looking for a spectacle independence post-cataract surgery, see, these are the options that are available. Even a monofocal with monovision, multifocal IOLs, that's the best. You have enhanced monofocal IOLs, micro monovision with these enhanced monofocal IOLs, and the EDOF IOLs. See, the enhanced monofocal and EDOFs, there is always a confusion which to call enhanced monofocal, which to call EDOF. So I'll be basically explaining on what is enhanced monofocals, and Dr. Soni will be speaking on the proper classical EDOF lenses. See, why did I say that you can achieve spectacle independence with a simple monofocal? See, all of us would have experienced, you have put a normal spherical monofocal IOL, and the patient is really happy. They say, no, I don't, you give post-op glasses for reading. No, sir, I can read also. Do I really have to? See, this is because literature, the studies have shown that up to 10% of these cases in which spherical IOLs have been put have that spectacle independence, basically because of the pseudo accommodation that they deliver. Okay, so it's basically the property of the spherical aberration in these IOLs that give them that. So when you're using an aspheric IOL, you are actually losing that. When you compare an aspheric IOL and a normal spherical IOL, the aspheric IOL has a 0.5 diopter, nearly 0.5 diopter, less depth of perception. So you might have put the basic IOL. Those people are the ones who are coming with saying that I'm happy without glasses. So one is that aberrations giving that this thing, and also if the patient has a against the rule astigmatism, compare no astigmatism or the other forms of astigmatism, studies have shown that there is a 10 times higher chance that these people can read without glasses. So so it's a spherical aberration. So let's see about the sphericity of IOLs. So a normal convex lens, if it is refracting, it doesn't give a point focus. Multiple foci would be there because the center focuses at one point, the periphery focuses at point. So the image that you get with the spherical IOLs is not that sharp. It's sort of blurred. You can see on this and this. So you modify the spherical IOL to give an aspheric IOL so that you get a sharp point of focus. So that is what you get with an aspheric IOL. And different companies come out with different sphericities or this thing. All these assume that the cornea has a plus 0.27 aberration, spherical aberration. So it's an attempt by these IOL manufacturers to either neutralize it or just keep it. So that is, they have their own calculations on it. Again, coming back to what I said in the first slide, the aspheric IOL definitely is useful because it increases the myopic contrast, mesopic contrast sensitivity, and it gives sharper vision for night vision and all. It is at least theoretically more advantageous, but it takes away that pseudo-accommodative effect that you get with a spherical IOL. As I said, there is a 0.5 diopter difference. So what is used in these enhanced monofocal IOLs to give that intermediate vision? So it's an aspheric surface. So what is modified is at the center, a little bit of curvature difference is made. Most of the lenses, it is on the anterior surface. In Envista, it is on the posterior surface. Rest remains aspheric. So it's a small point that is modified, and by using this spherical aberration, and mostly it is a negative spherical aberration that is produced in the center. Okay, it's like this. So when you examine the lens, you can't between a Technis 1, which is a normal monofocal, and Eyehance, which is an enhanced monofocal. You can't find any difference. There is no thickness difference there. But because of that spherical aberration, negative, you have a depth of focus. That is what gives that intermediate vision in this case, in these IOLs. So shown in a different way. Because of this negative spherical aberration, you get it. So comparison, they themselves, Technis 1 and Eyehance, they compared. They have shown that Eyehance gives a bit of intermediate vision. So why is this intermediate vision important? Because see, those who are in the who are undergoing cataract surgery, in that cataract surgery age group, they are mostly bothered about now TV, that distance, and now everyone has a mobile and they keep it wherever, or if they use laptops or whatever. So intermediate vision is very important into the daily living activities of these patients undergoing cataract surgery. That is why we are concentrating on the intermediate. But is that enough? See, okay, you have an intermediate vision, but see, some people might use mobile at a closer range. So you, in fact, have to attempt to give the full range of vision. So this can be definitely achieved if you're putting a multifocal IOL, or if you're just using a monofocal IOL, go for monovision. Micro monovision, I'll just tell you, it's just the magnitude of difference between the IOLs, that is monovision and micro monovision, or you go for an EDOF IOL. So in monovision cataract surgery, what we plan to achieve is to have a minus 1.5 or minus 2 correction in one eye, theoretically the non-dominant eye. So I was asking Srikanth today morning, do you really, because many of the top surgeons, they don't actually bother dominant or non-dominant. And as Srikanth was telling, like, if the patient has 630 vision only, it is very difficult to find out which is the dominant eye. So it doesn't matter, but if you can, it is better to go for the near vision in the non-dominant eye and leave the dominant eye immetropic for distance. So there is a huge difference. But as Dr. Anup said, there is a neuroadaptation happening. So that is also the reason why it doesn't matter if you go for a dominant eye myopic and non-dominant eye immetropic. It doesn't matter. Neuroadaptation happens, and these two get fused, and this monovision thing is called the blended vision. We all know about Dr. Graham Barrett. See, that is a go-to formula. Barrett true care. That is the go-to formula, at least for me, for most of us. Dr. Graham Barrett has never, he retired this year, a few months back only. He has never put a multifocal IOL or an EDOF IOL. He basically goes for monovision. It used to be monovision with the monofocal IOL. Then he developed that enhanced monofocal IOL. See, the difference between the enhanced monofocal IOL that Dr. Graham Barrett has developed and the iHands and other IOLs is that in those it is a negative sphericity, that is spherical aberration, that is added to the IOL. Here he has added positive spherical aberration. His reasoning for that is that, so for as I said, it's a presumed aberration for the cornea is plus 0.27. So for that to be neutralized, you have to add minus 0.27 microns sphericity, then add over that. So the modification is much more when compared to a posterior spherical aberration. Already the cornea has plus 0.27. You just have to add a little bit of magnitude. I'm not sure if it does practically make any huge difference, but that is the thought process behind the Ray 1 EMV IOL. And if you, so personally, I mean, I use a lot of iHands lenses. Sony swears by the Swiss Phobe IOLs. I've used Impress IOL also. The advantage with Impress is that you don't get a better injector system than the Impress Hoya injectors. Super. It'll go through 2 mm. So, and all these enhanced monofocal IOLs, I basically go for a minus 0.75 only. Because if you target minus 1, it might go to minus 1.25 and the patient might be happy. Here, even if you err, it might go to minus 0.1 only. And see, this is a graphic representation of monovision. So there is, it doesn't give a continuous range of vision. Micro monovision with a minimum difference, it gives a continuous range of vision. So basically, this is the reason my multifocal IOL practice only if the patient really asks for it. I mean, I basically don't have much chair time. And if you see the multifocal practice has come down after the advent of this enhanced monofocals and EDOF IOLs. So this is regarding the EDOF IOLs. Sony will be speaking on that. And basically this, I actually learned a lot making this presentation. Thank you.
Thanks, Dr. Srini. So just one question. Would you prefer to put a monofocal or a spheric monofocal? No, I'm not talking about enhanced monofocal. You said they have more pseudo accommodation.
Yes, because the sphericity is more theoretical, but most of my practice is spheric IOLs because the package is that way.
This is an honest opinion. Anyway, thank you for that. Now, our next speaker is Dr. Sony George. Actually, he'll be talking on EDOF-IOLs, the new paradigm in presbyopia correction. Actually, Dr. J.K. Reddy was supposed to come, but then because of personal reasons, last moment he could not come. So Dr. Sony, yesterday I requested him and he very oriented to take the topic. I'm really thankful to him. Dr. Sony, as we all know, he is the HOD of Cornea Cataract and Refractive, Vasanai Hospitals, Cochin and Thrissur. Over to Dr. Sony.
Thank you, Dr. Anup, for the kind introduction, and thank you for giving me an opportunity here. I'll be talking about from where Dr. Srini stopped. EDOF-IOLs, I would like to acknowledge and pay homages to my mentors, Sai Murli and Dr. Sundaramurthy. So why EDOFs? It actually started when the reading distance started receding. With the onset of computers, laptops and everything, the normal reading distance of around 33 centimeters, which our fathers used to read or we used to read in our younger days, it started receding. Now we don't even hold our mobiles at 33 centimeters or our books at 30, it comes to around 50 centimeters. And with the onset of the IT profession, people started rethinking about the distance at which people read. And second, the most important problem with the multifocals which used to give N6 vision was the photic phenomena. So something which reduces both reduces the photic phenomena, at the same time gives a functional near vision or intermediate vision was the reason why EDOFs came into place. So these are the different types. The type 1 is what Dr. Srini talked about, the pure spherical aberration based correction, and the one which on the pinhole principle. And then we have the refractive diffractive with the low near vision add. The first one to come in that range was the AT Lara. And then the hybrid multifocal EDOFs, which have lower near vision and manipulation of the spherical aberrations on the surface, and the modified central optic profile or the X EDOFs, which the Vivity and now the Hoya Impress are all about. So, like I said, the spherically modified is already, Dr. Srini is covered, IHAND, Swiss-Phobe, Ray-1 EMV, and the refractive diffractive is the AT Lisa, the Vivid from Orolab, which is again a wonderful lens, the Symphony and the Synergy, and the X EDOFs, the Vivity and the Impress. So these are all based on the functional working distance, and I'll skip this because Srini talked about it. Swiss-Phobe in my hands works very well, and it is comparable to the Mini-Well IOL. And it's got an anterior refractive optic element and which gives excellent distant vision and negative aspheric design in the periphery, just like any other negative aspheric IOL. And this is what the lens looks like. And I do micro monovision and I get good in near vision also in this patient. I'm skipping this. Okay, this is the AT Lara. So this has the light bridge optical design. So the near ads come in, or the intermediate ads come in lower ones, 1.90 and 0.95, and they get a continuous range of vision from 50 to 60 centimeters. So the light is distributed at 50 for distance, 15 for intermediate at 0.95 diopters, and 35% at 1.9 diopters. And this is how the lens looks like. It works very well. Intermediate vision is pretty from a range of around 50 to 70 centimeters. It works very well. Nearer than that, it is difficult. And the Auroview Vivid again is one such lens. See, if you look at the lens, it's got a central area of 1 millimeter. That is a refractive zone, which has got a diameter of 1 millimeters. And on either side, you have a diffractive zone of 2.1 diopters. So totally it makes 3 millimeters in the center, which is modified. And so it is an attempt to get our, see, this is the normal, the green one is the monofocal lens, and the red one is the multifocal lens, and The vivid covers more of intermediate, a little bit of near, and at the same time, if you look at the left-hand side, the visual distortions and the photic phenomena are minimal in these lenses. So this is the lens being injected. It is, if somebody has used a defined lens, it is similar to that. And the lens goes through a 2.8 millimeters. They are trying to reduce the incision size and the injector system. So after injection, you can see the central 4 rings, which is confined to the central 3 millimeters. These lenses you should always wash under the lens so that the tackiness remains and the lens sticks to the posterior capsule and reduces the PCO formation as well as the centration. I'll skip this. And this is how it appears in the postoperative period, a very well centered lens. And in my hands, almost with micromonovision, the patient achieves almost 6 N6 is around 70% of cases for near and almost 100% N6 for intermediate. Yeah, and visual disturbance are hardly anything. Nobody complains of glare or flare. The other, the XEDOFs, which I am talking about, is one is the Vivity. It is got, again, it's only the central 2 millimeters which is being modified. And here you have a smooth plateau of around 1 micrometers height, which is around the central 1 millimeter. And this stretches the wavefront and thereby provides a continuous extended focal range of vision. And the center portion shifts the wavefront forward to utilize all the available light energy. And this is what exactly happens. The stretching in the periphery and the shifting in the center. This basically gives a continuous range of vision and a reasonably good range of vision. And this is how it compares the monofocal this thing and the multifocals, and this is compared almost to the accuracy of IQ for the photic phenomena. So if earlier we needed to give a lens for a person who drives, we would have thought 100 times, but now Vivity is a lens we can safely implant in a patient who drives even at night. And in my experience, this is the lens, how it looks like. You have the central bump, okay, the plateau, and then the hole in the center. And the loading, everything is in the typical accuracy of platform. And this is the injection. It goes through 2.2 millimeters. Now all these come in the Clarion platform. Yeah, and this is how the lens looks like. And this is the lens just to show the centration of the IOL. Post-surgery, you can see the rings and not the ring, the plateau in the center. And this is how the lens looks like post-operatively. You can, on slit lamp, you can see the rings very well. And in my experience, I do a micromonovision. I'll come to that after finishing the next lens. The next one is the Hoya Impress. So here, again, they have done almost the same kind of correction in the center, but not the plateau and the central this thing, but they have made modification in the central 2 millimeters. But all the transitions or the variations happen in the subsurface area. So the surface looks very smooth. Only the subsurface area, the modifications have been made, and like you see, there is an extended range of vision in these lenses. And these, like Dr. Srini said, the Hoya lenses are just wonderful because of the injector system. It's almost 100% foolproof. And you can adjust even how much of the tip should go inside the incision. So that's wonderful. Like you can place it where, if you want to place it directly into the bag, it's very easy to do that. And this is how the lens goes in. So I'm just trying to stabilize the eye, and then once it's very easy. You can either go for the rotation or the push. I am always a fan of the push mechanism because you can use it in a single-handed. Otherwise, you have to come out and then start screwing. And in a patient who is under topical, if he moves a little bit, you're in tough situation. So it just goes in very smoothly into the back. Actually, you can use, there is a small tip, if you turn it a little bit, you can use that to engage and put the lens inside. So, yeah, this is again another lens which goes in the similar way. So for me, there are two protocols. So a patient who generally prefers a reading distance of 50 to 70 centimeters, and he doesn't need to come near, I would make him immetropic in both eyes. That is the protocol 2. But most of my patients would say, I would also like to read. And here I aim at immetropia of around 0.25 in the dominant eye or 0, depending on the reading this thing, and 0.5 to 0.75 in the non-dominant eye. This way it works very well, and almost 100% of the patients are able to read N6 at a distance of 40 centimeters and with reasonably good illumination. You have to stress upon the fact that you need more illumination because the light is split, so you need more light. In the other protocol, immetropia in both eyes, they still can read, but with very good illumination, maybe around 50 centimeters. So this is how I go about with my EDO 5Ls, and I think it's definitely a promise for the future, especially with the number of people, even ladies who are in the cataract surgery age group who are still driving and active, even driving at night. Thank you very much.
Thank you, Dr. Soni, for that wonderful presentation. My one doubt here is how would you go about going with EDOF lenses and all in post-refractive surgery cases? And maybe Sachin can add on to this, because from what I understand, Shah Rukh Khan created all these ruckus because he was implanted a Vivivity and he had undergone a hyperopic LASIK. Hyperopic LASIK. So, if a patient has undergone LASIK, Sajjan, like if it is a myopic LASIK, that induces more of negative sphericity, right? And you are adding that. See what happens in those cases if you are putting an EDOF, enhanced monofocal, and what might have gone wrong in Shah Rukh Khan's case?
There's a joke about it. You know about that, right? He insisted on the SRK formula.
Sajjan, your comment.
I don't think hypermetropic LASIK in the first place is a good idea. I mean, I don't recommend that much.
Exactly, that was what Srikanth was telling today morning. With that, we'll have a lot of photic phenomena, even otherwise. Yeah.
So after that, to put an EDOF on that, I mean, that will be like, and especially in Shah Rukh Khan, I mean, you have to be very, very careful. That's what. I mean, it is a difficult situation. Hypermetropic LASIK and then to put an EDOF, I don't know. I mean, there is no clear-cut answer to that.
Yeah, if it is a normal myopic.
Myopic LASIK, it is okay. It doesn't matter much. Yeah, because you can behave with normal IOL. You can that selection with the Barrett's formula. I don't think you have to think much about that. Yeah, only the hypermetropic LASIK is the issue. I mean, people who have done the LASIK after 40 for the presbyopia, that is where the issue comes. Yeah.
Okay.
I think any person who has undergone a refractive surgery, you have to be very, very clear that there is always an error of a residual chance of having a residual error. How much ever precise you are, whichever formula you use, you will still have. And you have to motivate them accordingly, spend more chair time. Most of the time, they will accept it. I've done a few cases. But then you have to be very clear about it. Otherwise, the chances are always there that there can be error. Even if you have all the pre-K values, everything, still there can be a chance of error.
So okay, we can have
Yeah.
more discussions, but
Just one thing, for those such cases is what they are promoting, the light adjustable lens.
But the feedback for light adjustable lenses from US is extremely.
It's not very easy. It's very cumbersome. But then,
So now I invite Dr. Jason. Everywhere I go, when he is there, I tell he is still the best cataract surgeon in India. Wherever I go, when I present, I tell Dr. JK, though I am from RP Center, Dr. JK Reddy is my teacher. This is another thing that I tell. Jason will be speaking on trifocal IOLs.
Good morning. Good morning. I began implanting multifocal IOLs in early 2000 with array silicon refractive multifocal. Later I began implanting restore diffractive multifocals, but however, I could never fully accept multifocal IOLs because of due to the recurrent dissatisfaction expressed by some of my patients. This is one example. This patient underwent surgery for early cataracts. He had only a few cortical spokes. Although he achieved 6/6 and N6 both eyes, he still reported poor overall visual quality, along with issues of glare and halos. It was not the glare and halos that troubled him the most, rather the overall visual quality, which was poor. He felt that quality of vision after surgery has deteriorated, though he had a 6/6 and N6. So I went for an IOL exchange. The IOL explantation in the second eye was performed after 1 year. The refractive outcome was not very ideal. You can see I got myopia both eyes. However, patient said his vision is significantly better than before. I assumed that the patient dissatisfaction with the multifocal IOL was due to loss of contrast sensitivity. Meanwhile, the trifocal lenses were introduced. You know that they are a combination of two bifocal patterns. The first pattern has an addition of 3.5, which is the first diffractive order that is used for the near vision. You should know that the zero order is for distance. Therefore, the second diffraction order occurs at 7 diopters. So that 7 diopter is not used. It is the lost energy, and it is not used for the useful vision. So I think that is you know that 20% of light is lost in multifocal lenses. The second pattern's first order provides an addition of 1.75. So this is providing the intermediate vision. The second order is the bottom one. This is providing the intermediate vision. The second order has a divergence of 2 into 1.75, that is 3 diopter. So you can see that second diffraction order of the second pattern is reinforcing the first pattern's near vision. That 3.5 is added to the first pattern's 3.5. So approximately you gain 5% of light energy more in trifocals. So the percentage of lost light energy, which is 20% for standard diffractive bifocal IOL, is reduced to 15%. So I was convinced by this physics and physics behind trifocal lenses, and I adopted them immediately. Within few days, I implanted 12 trifocal lenses. And this was my 12th patient who also had early cataract. After surgery, he achieved 6.6 and N6 in that eye. However, he reported poor quality of vision, both near and distance. He was happy with intermediate vision. He said he was hesitant to undergo the surgery in the other eye, and he went back. A year later, he returned and had a unifocal lens implanted in the other eye. He was not ready for the multifocal or trifocal. He was satisfied with the outcome of the second eye and requested an IOL exchange in the first eye. This is another case. 50-year-old neurosurgeon wanted presbyopia LASIK. He was advised elsewhere that trifocal lens will be a better option, and he underwent trifocal lens in both eyes, achieving 6.6 and N6 both eyes. He said he can see objects at distance and near and intermediate ranges, but missing the object's finer details. This is the other eye of the patient. He has not returned to work since his surgery and has now been almost a year. He was taken up for IOL exchange, and IOL explantation was attempted at another facility earlier, but it was unsuccessful probably because of anterior capsular fibrosis and presence of plate haptics. To overcome the capsular rim fibrosis, you can see we have done radial cuts on the anterior capsule using YAG laser. So this is how it was explanted. Explanting, this is not an Indian IOL. I don't know which, it's I think Turkish or somewhere. So I could explant it because of that radial cut. The issue was extension of that radial cuts while manipulating. But I was lucky it didn't get extended, and I could explant that trifocal. I didn't divide the lens in the anterior chamber because I've never done it for a plate haptic lens. It was explanted and implanted a unifocal lens. I could place it in the bag. The second eye IOL exchange was done within few weeks. One day after, residual myopia was targeted and achieved in second eye. Patient was happy with the results. You know that clear lens extraction with multifocal or trifocal lens implantation for presbyopia has not gained widespread popularity. This is because these lenses causes loss of contrast sensitivity. Patients with early cataracts also may not tolerate multifocals and trifocals because of the same reason. These lenses tend to be better tolerated by patients with advanced cataract. My choice for presbyopia correction in cataract is EDOF lens or enhanced monofocals. Thank you.
Jason, see, these EDOF lenses, I mean, you all agree with me, right? He's the best. His hands and everything. Okay. See, the EDOF lenses still have that photic phenomena, whatever. I mean, it's not that in these EDOF lenses, the photic phenomena of multifocal lenses are totally eliminated.
No. Actually, it is there. I'm implanting Vivity and IHANS. The problems are there, but it is less. I feel you look at the lens, count the number of rings. If rings are more, it is going to create more issues. if it is directly proportional to the number of rings. That's what I feel. And if there are no rings, they are more problem.
Yeah, he is finished.
Yeah, it's over.
He is finished.
It's over.
He is finished.
Thank
He is
you.
finished. Okay. See, when one second. Dr. Srikanth probably was the first person to use multifocal lenses in a big way. I believe he was using the Xeon rigid multifocal lenses, right? See, would you have continued because you didn't have much of a complaints with those lenses. If that was available, because somebody, one Sadish Shet is there, who does some things with, he has come out with a rigid IOL with these things. If that was available, would you still be using it? Okay. Anup.
So for a second, like for the discussion, let's talk. Let's forget about the packages. Like we are beginning surgeons. I use multifocals. I use trifocals. I use UDOF. But then for older people, like old ladies who just sit at home, I advise multifocal. Who comes to me asking out. Otherwise, youngsters, I would. I suggest unifocals, like for driving, because when I use UDOF, I think the distant vision just comes down. Is it like that? Like what age would you advise multifocals? And like, is it same thing like for old people who sit at home just to read?
Yeah, and exactly. That is how we have to decide which lens to put. Somebody who is very active life, it's young and old is doesn't that much of a difference. But somebody who is really active, a lot of outdoor work and all. Either I think the enhanced monofocals would be best, because
what brand? Like I've been like if someone asks, like some patient asks us, which one should we suggest? Like Swiss Bob is good, Magnificent is good. Yeah. Define has 2 rings, 2-3 rings. I think I have one patient who complains of glare after Define.
Generally you prefer some brand. Generally we all have, and if you are happy using that, then we don't change. We try to stick with that. So all of them, I think, even the Indian ones, Swissfob is good, even the iHands is really good. So this is my experience with iHands. I've used a lot of them, and post-operatively you see the patients, they are happy.
Then what patients would we advise multifocals? Like
multifocals, more like when you're talking not of IDOFs.
No. What compared to IDOFs, like for the package.
Multifocals would be like those who are more into near work and who don't do driving, like you said. Those like people who don't drive much, basically. Age is not an issue because a lot of old people still drive. But those who don't drive much, they basically like to read and are at home most of the time, or just so such people would be better candidates for multifocals. So that is what I said. The most important is the patient selection, because what Jason showed just now, he had to. So for a neurosurgeon putting a multifocal, that was like it was like asking for trouble.
The cost of multifocals is much more than that. So I think I personally feel it's not worth the cost of what the multifocal.
No, you get the Indian ones also. See, for example, a retired college professor who would like to spend most of his time reading. For him, definitely a multifocal or a trifocal will be the one of choice, a person who is not driving around much. But before all this, you should make sure that this is the cause, the lens is the cause. Probably you are looking at a dry eye which is causing the problems, okay, or something else. In fact, you can have even distraction techniques, like Dr. Anup said. We call it neuroadaptation, but then you can give some distraction techniques to the patient, and most of the time it works. Beyond science, there is something else which helps us. And so always look at the ocular surface. Many times we most of the time forget that the tear film is one of the most important refractive surfaces other than the cornea and the lens. So pristine tear film most of the time improves. So maybe a part of it is because of this thing, but further reduction because of this, or a fine change in the retina may be the one actually what makes him uncomfortable. And we all know that the photic phenomena is directly this thing with the loss of light and the loss of contrast sensitivity. So always have a look at that and then try something else. And like Dr. Anup said, whichever works best in your hand, keep doing it.
And what I
Age should not be an issue. We have been asking Raki to include us in the Young Ophthalmology Society of. So age should not be. Okay, Mridula.
Yeah.
Exactly. So age is not the issue.
And one very important point you said is that most of these IOLs are all technology and evolution. They are not perfect, but the charges are too high. So I also definitely agree that they should not be charging so much for those lenses which are basically inherently not perfect. But then that is, I think, what is the trade and those things. Yeah. Okay.
It should be that the premium surgery is by the surgeon, not because of the IOLs. So that is something, I mean, we are still not out of that mode. Like, we are the premium. That's it.
That is a take-home point. Thank you everyone. Thanks for your patience. I hope you learned some important things and everybody has given the honest opinions. Thank you. Thanks to all the speakers.